Hi, I'm Bruce Earls, and I'm the chairman of the Department of Cardiovascular Perfusion at the State University of New York, Upstate Medical University. And I'm happy to have a few minutes to talk to you today about my profession in clinical perfusion. A clinical perfusionist is a highly trained medical specialist. We're also known as extracorporeal technologists, and we are operators of extracorporeal technologies. Let's take those words apart. Extracorporeal, extra as in outside of, corporeal as in the body. We circulate blood outside of the body, and we operate artificial hearts, artificial lungs, artificial kidneys. We use blood pumps. May they be roller head or centrifugal or axial flow catheter based or pulsatile and implantable. We use lots of blood pumps to operate as artificial hearts. We use oxygenators to serve as artificial lungs. These are devices made out of polymethylpentene or polypropylene, and they are membranes that we put blood in close contact with, and we control the airspace on one side of the membrane and the blood space on the other side of the membrane to effectively control diffusion of respiratory gases. And we also operate artificial kidneys in the sense that we operate hemoconcentrators where we can remove volume, plasma water from the patient's blood and anything that is dissolved in that plasma water. So solutes that would be dissolved. So it's kind of artificial urine. We apply these technologies to certain medical procedures and techniques. The thing that we do most is cardiopulmonary bypass, and we do cardiopulmonary bypass in the operating room as a member of the open heart surgery team. We can also apply these extracorporeal technologies to something called extracorporeal membrane oxygenation, or ECMO. ECMO is often done in the intensive care units for patients with severe heart and or lung failure. We can also use these blood pumps as ventricular assist devices, aka a VAD, or total artificial hearts for patients who have severe heart failure. You know what might be best is if I could take you into our sim lab and show you what a perfusionist does. So let's head up to our sim lab now. And here we are in the sim lab now. Here's one of our faculty members, Ed Darling. Today he's playing the role of a cardiac surgeon, helping this simulated patient get a heart repair. To do that, the role of the perfusionist is going to involve the operation of this heart-lung machine here. This is a new Spectrum medical pump, brand new, latest stuff on the market here in our sim lab, ready for your learning. As you can see, there's a lot of technology in these heart-lung machines, highly computerized, and also some basic pumps. Here, let me show you a few things. This is a roller head pump. A roller head pump takes a piece of tubing, runs it through the raceway, and there's a little wheel here that can roll, and it squishes that tubing and pushes things forward. We control pumps like that with knobs like these. So this white knob here controls that pump over there, and as you see when I turn this knob, that pump starts to spin. There's another kind of pump, and those are centrifugal pumps. Centrifugal pumps look like this. This is a motor unit down here, and this is the disposable pump part. There's parts spinning in there. You might be able to see some spinning action going down here in this little crack. But there's an inlet here and an outlet there, and this is pulling blood in and pushing blood out based on how fast that's spinning. We control those RPMs with another knob over here, or with a little touch setting here, so I can watch the number, increase the RPMs. I can hear the pump spinning faster, decrease the RPMs, pump spinning slower. And when the pump is in the arterial position, that's essentially controlling the patient's cardiac output. So that's a little bit of our technology. Let's actually show you how we connect this up to a patient. So let's go up to the field. This is our patient who's going to receive some open heart surgery. You're going to feel much better soon, sir. This will be their open chest. Since we don't teach how to do the surgery, we're not teaching surgeons, we're teaching perfusionists. So you'll see there's no heart in that chest. But what we have here is a cannula hooked up to our simulator that would be in the patient's arterial system. So the surgeon has placed that cannula. He's going to bleed any bubbles out of it. And then you can connect that up to the heart-lung machine. That loop that he's separating there is a connection between our arterial and venous lines. He's going to take the arterial line and connect it to the arterial cannula. And we can't leave any bubbles behind there. Obviously, pushing a bubble into the patient's arterial system would be very bad for the patient. So one of the things perfusionists do a lot of is make sure that we don't pump any air or emboli into our patients. Now the other cannula over here that he has would be connected to the patient's venous system. So with the cannula in each of these positions, we can drain blood out of the venous system through our heart-lung machine and push it back up into the arterial system. So let's follow that track now. The venous line right there in the surgeon's hands comes down here, past some safety devices, past some flow meters, and to the top of our reservoir. The reservoir would be the bucket where we're going to collect the patient's blood. Only we're not collecting it so much as we're circulating it through that bucket. As fast as it comes in the top, we're draining it out of the bottom with this pump. So that flow right now happens to be sitting still, but later on it'll be just as motionless, but there might be 5 liters a minute of flow flowing through there. So the blood comes down into the pump. We push it out of the pump and over to an oxygenator. This oxygenator functions as the patient's artificial lungs. This is where we're going to control the gas exchange. We control the gas exchange by controlling what that artificial lung breathes. And we have a device for that over here, where we can dial in the percent oxygen that the artificial lung breathes, perhaps 100%, perhaps 22%, and we can control how fast it's breathing. So this is basically like the respiratory rate and the tidal volume of that artificial lung. Like right now, it would be set for 4 liters per minute of breathing of 22% oxygen. So this pump is the artificial heart. This oxygenator is the artificial lung. We pump blue venous blood into this oxygenator. It comes out the other side, it would be red. Red arterial blood would go back up into the patient. As long as we're here, this is an artificial kidney of sorts. This is a hemoconcentrator. We use that when we want to change the volume status of the patient. So we have artificial hearts, artificial lungs, artificial kidneys as part of our extracorporeal technology. So after we've drained the blood out, changed the oxygen saturation, and send it back up to the field through more safety devices, up the arterial line to the patient, and right back into their arterial system. With that done, we can do cardiopulmonary bypass. We can turn off the patient's heart, turn off the patient's lungs, and keep them alive with the heart and lung machine. And that is the equipment operated by a clinical perfusionist. Let's go on bypass. So if I were getting ready to go on bypass, and by the way, this is a very brief summary, I'd have to place some metal clamps on the venous line, maybe another clamp on the arterial line. And there are other ways of doing this. In fact, this is a highly technical pump, so I could do this with some electronic devices instead of manual clamps. We would dial in our FiO2 to maybe 75% and our flow to about what we think our blood flow is going to be. Let's say it's going to be about 4.5 liters a minute. And then we get ready to operate the machine. Our arterial flow right now is set to 0. All of our other pumps are off. Doctor, are we ready to go on bypass?
Yes, we are.
Okay.
Bypass and go to full flow.
Very good. Going on bypass, going to full flow. And take the clamp off the venous line and watch that turn red. See the blood come out of the patient? Start to accumulate in the venous reservoir. But now, I'm draining too much blood out. The blood pressure is getting low. I better hurry up and put some blood back in. I'm doing this really slow so that you can understand it. You see it start to pump forward. I'll start turning up the flow. Now we have about 5 liters a minute. And our patient's blood pressure is looking a lot better at 55. From here, the surgeon would begin their procedure, and they may take a cross clamp and put it across the aorta.
Go down on flow.
Going down on flow.
Your cross clamp is on. Give some cardioplegia.
Pumps back up. Cardioplegia is coming on. See, this pump here is the Cardioplegia pump. And it is infusing a high potassium solution directly into the coronary arteries. Let's watch what that does to the patient's hemodynamics. You see already they're starting to fibrillate as the potassium reaches the myocardial cells. And as we continue to deliver, we'll reach full asystole. The patient is literally flatlining. And this is something that we do every day in the cardiac operating room. We arrest patients' hearts so the surgeon can have a motionless and bloodless field.
Off my cardioplegia.
Cardioplegia is off. I'll let you know when 20 minutes have passed. Now, as the perfusionist operating this equipment, I would continue to watch my reservoir level. Watch all my pressures, the ventilation of the oxygenator, the flows of all my pumps, and I'll draw samples off of the circuit at ports like these to send to the laboratory and analyze the blood for its oxygen, CO2, electrolytes, acid status, etc. Let's finish up this procedure. Coming down on flow.
Your cross clamp is off.
Okay, pump back up. Cross clamp time was an amazing 2 minutes, doctor. You are very fast. Our patient's heart is responding. They're starting to beat again on their own. And we can start to wean from bypass now. To wean from bypass, I have to restrict the drainage, take less blood out of the patient down this venous line, and let some of this blood that's in the reservoir start to accumulate up there in the patient. So let's try that. Is it okay to wean from bypass, doctor?
Yes, let's come on down on flow and fill the patient.
Coming to 3/4 flow. Reservoir levels starting to drop. Patient's starting to become a little pulsatile. So it's time for me to turn these knobs down and catch that reservoir level.
Keep coming down.
We're at about 3 liters.
The filling of the heart looks good. Keep coming down to 2 liters.
All right. Reducing the flow to 2 liters.
Come on down to 1.
We're almost at 1 now. Add a little more clampage.
Come off bypass right there.
All right, coming off bypass. Clamping the arterial. Venous is clamped. Purge is off. We're off bypass. Patients supporting themselves now. Doctor, excellent job.
Thank you. You too.
So how did you like that tour? There's a lot of pretty sophisticated instrumentation in that room, isn't there? Being a member of the open heart surgery team is not easy. It's stressful at times. The work of a clinical perfusionist is actually a matter of life and death for our patients. And we work with some of the sickest patients in the hospital, and we try and improve their quality of life. If you enjoy cardiopulmonary physiology, and you're not afraid of sophisticated technology, clinical perfusion may be a great career for you. So let me tell you a little bit about our educational program so that you can understand how you could become a clinical perfusionist. Our educational program at SUNY Upstate is part of the State University of New York. That's one of the largest university systems in the country with 64 campuses and about 500,000 students. There are 3 medical universities in our collection of campuses. Here we are located right in the smack dab in the center of central New York in Syracuse, New York. In our local community, there are 3 universities and 3 colleges all within about 6 blocks of each other. It's a very academic hub of our city. On our campus, we have a College of Health Professions, a College of Medicine, a College of Nursing, and a College of Graduate Studies. We also have our own hospital, aptly named University Hospital. This is a picture of our campus. In the College of Health Professions, one of the departments is the Department of Cardiovascular Perfusion. It's the oldest university program for clinical perfusion in the United States. We graduated our first associate's degree class in 1975. We transitioned to a bachelor's degree in 1999, and in the year 2020, we graduated our first master's degree class. The faculty members in this department include myself, Bruce Searles, as the department chair. We have Mr. Ed Darling, a clinical perfusionist for over 25 years. His administrative role is as the clinical coordinator. He interfaces our department with the 17 different hospitals that provide clinical education to our students. Recently, we were joined by Mr. Jeffrey Riley, a legend in the field of cardiovascular perfusion. He has over 40 years of clinical experience and has been program director or instructor at more than 4 different educational institutions. Most recently, Dr. Ayesh joined us. He is an Egyptian-trained MD, PhD, with a specialty in cardiology. These 4 individuals are primarily responsible for your didactic education while on campus. In our department, we have a 4-step plan for your successful education, and it is heavily weighted with the emphasis on simulation. We have 12 credits of simulation courses, which come up to over 650 hours spent in the sim lab each year by our students. In the sim lab, we do high fidelity and low fidelity simulation. We have 2 operating rooms, and we have 3 spaces that are set up as intensive care units for practicing ECMO. Not only do we practice fundamental skills in isolation, but we specialize in running full mission cases. A full mission case means that when you come to your training session, you are given patient information and you do everything that you would do in the course of a normal cardiac surgery event, starting with reading the patient's chart, doing the calculations, and selecting the equipment, assembling the equipment, priming the equipment, interfacing the equipment with the surgical field, and then conducting the entire procedure with all of the fundamental skills included in that procedure. We spread our curriculum out over 3 semesters. And in semester 1, we focus on the basic skills. We have recent publications in the literature identifying what the fundamental skills are for cardiopulmonary bypass and the elements that perfusionists do when they're conducting these skills. After the first 10 weeks, you are operating a heart-lung machine independently in the sim lab. In the second semester, we move on to case management. Now that you have practiced the fundamental skills you learned in semester number 1, we can apply those fundamental skills to specific cardiac surgery procedures. One of the benefits of training in the simulated environment is that you can control the clinical caseload. That's not at all how an operating room works. In the OR, if you show up for cases, you're going to see whatever patient is scheduled that day. In the sim lab, we can make sure that the cases that we schedule in the sim lab are matched well to the didactic curriculum you're getting in the classroom. So if you're receiving lectures on coronary artery disease, you're going to see simulated cases based on the CABG procedure. And if we're studying defects of the mitral valve, then our cases that week will be about mitral valve procedures. So simulation allows us to match our clinical experience to our didactic experience. Semester 2, you practice the 5 most fundamental adult cardiac procedures so that you are ready to handle whatever comes your way in the clinical operating room. In the third semester, we move on to crisis management and ECMO. You'll be challenged with equipment failures and patient crisis situations, which you hope to never use in the clinical environment, but these low-volume, high-risk events do happen. And when they do happen, it is critical that your activities are appropriate and timely. It is hard to develop competence with emergency procedures that you so rarely conduct in the clinical environment. But it is so critical that you have these skills. And that's why we dedicate 7 weeks in the summertime to practicing crisis management procedures. We also spend 7 weeks practicing ECMO, or extracorporeal membrane oxygenation, an application of our pumps and oxygenators in the intensive care unit. Perfusionists often have a very important role on ECMO services, though the ECMO team is even more multidisciplinary than the operating room. While observing and practicing your skills in the sim lab is very important, sometimes it's difficult to learn in the moment. And for that reason, we back up everything that happens in the sim lab with the power of video. All of our sim labs have multiple cameras hard mounted on the ceiling, and they run to a video encoder which provides a live feed of everything that happens in that room. Here you see that in a simulated event, there may be an instructor. For instance, this could be myself or Mr. Darling or Mr. Riley working with a group of 3 students. This student is actively operating the equipment while the other 2 students are observing the entire event. Everything that we do in this room, and everything that I say, and everything that I write on the screen is captured to video and uploaded to a cloud server. That server is streaming the video live, so other students on campus or elsewhere could watch and learn from that experience. Additionally, the cloud server is keeping the video available for asynchronous learning so that the student who pumped the case can actually watch their own event. And while I say can actually, I should say must actually watch their event. It is a requirement of everybody in the sim lab that they write about and develop a plan for improvement of every case that they pump in the sim lab. This reinforces the learning and exposes the students to things that they didn't catch at the time because they were so busy trying to operate the equipment. Through this process of applying video to our simulated cases, the students receive all kinds of feedback. They receive peer feedback from the other students that watch their video. They receive the expert feedback of the clinician in the room, and they have to write about their own personal experience. So there's lots of reinforcement of the things that should have been learned and the things that are yet to learn. This is another way that simulation is markedly different from learning in the actual operating room. In the operating room, the clinician that you're training with, their most important job that day is to take care of the life of a patient, and the student will never be the most important person in the room. In the sim lab, the student is the most important person in the room. Everything that's happening in that room is for the benefit of the student. In addition to our simulation curriculum, we have a rigorous classroom education. This also covers 2.5 semesters, and it is 36 credits that is entirely consistent for every student in the program. Our simulation curriculum and our didactic curriculum are matched together so that the cases and the lectures are in synchrony. Our semester for the program runs over 5 semesters, and in the first semester there is a little bit of observation in the hospital, in our local hospital. There's also simulation experiences which have their partnered classroom experiences. And the emphasis in this semester is fundamental skills. In semester 2, the simulation emphasis turns to case management, and the lectures appropriately move to pathologies and surgical corrections, and the pharmacology used during the procedure. So again, the classroom and the simulation are matched. And we continue with our observation. In semester 3, we cut that semester in half. And in the first half, it's more of the same of simulation, being crisis management and ECMO, matched with classroom work. But after 7 weeks, we break the semester, and the students then depart to their first clinical experience. The rest of the curriculum largely is off-site clinical experiences, which represents 1, 2, 3, 4, 5, 7-week clinical rotations. At the end of these 5 semesters, you have completed nearly 90 credits of coursework, 150 to 180 clinical cases, more than 1,300 hours of clinical experience, and are eligible to sit for the American Board of Cardiovascular Perfusion's Clinical Perfusion Certification exam. Another value-added element of the SUNY program is our Capstone and Thesis track. As we've told you so far, that every student comes through and starts at the same point and continues as a single cohort through a core curriculum, which includes classroom and simulation. By the middle of the curriculum, however, the students divide themselves into clinical or research track. If a student has an interest in doing clinical research in a field of cardiovascular perfusion, then they can complete a 10-credit research thesis while they are working on their 32 credits of clinical preceptorship. If the student would rather not do research and wants to focus on a clinical specialty, then they can take the clinical track. The clinical track is referred to as the Capstone track, and we have 5 different Capstone options to select from, including simulation, leadership and management, ECMO, ECMO and ventricular assist, pediatric perfusion, and perioperative blood management. Students selecting a clinical track will do 10 credits of specialized coursework in their field of specialty. Many of these specialty fields offer the opportunity for an external certification exam. For instance, if you specialize in perioperative blood management, you can take the perioperative blood management technician or specialist exam offered by the American Society. If you specialize in simulation, you may take the Certified Health Simulation Educator exam offered by the Society for Simulation and Healthcare. If you take the ECMO capstone, you may complete the Certified Adult ECMO Specialist exam offered by the American Society of Extracorporeal Technology. AMSECT is also working on an examination for pediatrics, and there are multiple quality and leadership exams that are offered from external specialty bodies in the field. We believe this is value added because now you may, if you attend our program, graduate with your master's in clinical perfusion, sit for the American board to become a CCP, take the state licensure exam to be an LP, and you may also have other initials after your name based on the certification exams that you elected to take and were prepared for based on your capstone selection. And of course, the education is supported by rigorous clinical rotations. We have 5 7-week rotations, and you must rotate through at least 4 different hospitals as you're doing your education. At the moment, these dots represent where our clinical affiliates are across the United States. So what can you do with a SUNY degree? You can get an excellent job. Our job placement is 100%. Our student retention is 87%. If you get into our school, you're probably going to graduate from our school and have a great job and pass your certification exams, which are necessary to get your state licensure. Well, looks like I gotta go. Dinner time, and I gotta get the pizza. I hope you've enjoyed this presentation. Well, thanks for spending this time with us today. I hope you enjoyed learning about the career of clinical perfusion, and if you have any questions, by all means, call our admissions department. We look forward to hearing from you.